Hello everyone, this is Sherry Bowringer. I'm an associate editor for Prescriber's Letter and Pharmacist Letter. We're going to be talking about appropriate drug regimens for H. pylori. And you know, the whole reason this particular topic is coming up is largely because there's been a lot of clarithromycin and tetracycline shortages lately, and because of these shortages it's impacting H. pylori therapy, you know, what can be used instead. To help us with our recommendations, we have with us today H. pylori expert Dr. David Graham. And so Dr. Graham, in just a moment we're going to be going to the draft, but I do have a question for you before we even talk about the shortages and what to use instead of clarithromycin or tetracycline, and that is, what should we be recommending for first-line therapy for H. pylori? There are just so many different options. There's triple therapy, there's quadruple therapy, there's concomitant therapy. What should we recommend first-line?
Helicobacter pylori therapy is changing. It's being removed from the GI category and put in the infectious disease category.
Right.
In that the GI folks, of which I'm one, were very comfortable with poor outcomes, which is not acceptable for a treatable, common, but potentially serious infectious disease. And triple therapy was good for a while, but the high rate of clarithromycin resistance has made it now where it, unless you know the patient has a clarithromycin susceptible organism, the results are just unacceptable. They're below 70%. And so we have switched for first-line therapy from that triple therapy to a four-drug regime where you add metronidazole either as sequential therapy or as concomitant therapy, or with the four-drug bismuth tetracycline quadruple therapy. So we have really two separate therapies that are different, that either one can be used first and the other one can be used as backup if they fail for the first one.
Okay, this was our hardest question to answer on this topic, and that is what to use. And you have just told us triple therapy should not be first line, correct, Dr. Graham?
Unless you know the patient is susceptible organism.
Okay, unless you know that they're susceptible to the clarithromycin. Right, okay. So then you have these two four-drug regimens, that the quadruple therapy that we often think about with the bismuth, and then this concomitant therapy that has the clarithromycin, amoxicillin, metronidazole, and a PPI. Between those two, do you have a favorite? Which one of those two should we be recommending?
It's a toss-up.
Okay.
It's availability, the patient, what they've taken before. If they've taken a lot of clarithromycin and metronidazole in the past, for example, if they're a woman that's had metronidazole use, or we see Hispanics that have a high frequency of resistance in both, then I'll start with the bismuth one. But typically, it's a toss-up.
Okay.
So Sherry, it's Craig. Can I ask you a question?
Yes, you can ask a question, and I have one, Craig.
All right. In the era of electronic medical records, I thought there'd been a couple recommendations to try to find because amoxicillin and flagyl are both commonly used for other conditions. But is there data that if you've been exposed to one or both of those in the last 6 months or 12 months that we really should try to avoid those?
That's a good question.
In America, at least in most of the world, amoxicillin can be used over and over again, and resistance almost never occurs. Metronidazole resistance does occur, occurs frequently, but with the bismuth quadruple therapy, you can largely overcome it if you stick with the doses and maybe go to 14 days.
So when you think it's okay to use metronidazole even if they've been on it in the last year for a different reason?
Yes.
Okay. Good question, Craig. You know, my question is based between this quadruple and concomitant therapy. Like you said, it was a toss-up between the two. I was looking at it, and if it was me with H. pylori, I would pick concomitant, and it's because it was twice daily instead of 4 times daily. Do you agree with that for that reason?
Well, it's certainly more convenient to the patient, and when we've done studies, we find that side effect profile of the two are about the same, but
Okay.
there are more complaints, I think, from the bismuth, and you have to talk more to the patient because
Got
you have to
it.
tell them when you get black stools, don't call me at 3 a.m. It's not blood,
Okay.
etc.
Yeah. So from an adherence standpoint, that concomitant might be easier to adhere to. And
Of course, in the ID world, they hate giving extra antibiotics if you might not need them, but I
Well,
presume
that's
resistance
true.
is just going to keep growing with this organism.
That's true. That's a point there, because it's one less antibiotic if you stick with the quadruple therapy. Karen, some audience questions?
Yes, thank you. We talk about giving extra metronidazole if you're using the Helidac. So one question is, what's the best way to give that extra metronidazole?
I just simply give them, for each day I give them 3 extra tablets and tell them that for the breakfast, lunch, and supper one to take the extra tablet, and then they can throw away the one for the bedtime or they can take it, depends on if they want to.
Okay.
A little bit more probably is not going to hurt them, but less, particularly if they have metronidazole resistance, will reduce the efficacy.
Now, a follow-up question to that is that the tetracycline dose in the Pylori combination is a little less than what's considered optimal. Would you give extra tetracycline if you're using Pylori?
No, it's very close. We like 2 grams, and it's close. And in clinical trials now, there have been a couple of big trials, and in fact, we just finished another one of our own trials, and it seems like it works fine with that dose. I'd like a little bit more, but it doesn't look like it's necessary.
Okay, so it's not necessary. Okay, that's helpful. Thank you.
Okay, and getting back to the shortages, so what we've been able to find in our research is if somebody can't take tetracycline, there's really not an alternative tetracycline product that can be used for H. pylori, and same with the macrolides. If somebody can't get the clarithromycin because of the shortage, there's not an alternative macrolide. Is this correct, Dr. Graham?
For the macrolide, yes. We really don't know about whether we could give doxycycline in place of metronidazole, in place of tetracycline hydrochloride. There were early studies that said no, but those really early studies were not the current regimen with BID, PBI, etc. And there have been some studies using doxycycline with very good results. So I don't know the answer to that question, and at least at my hospital, VA, where we don't use combination drugs, if we want to use that combination, we have to use doxycycline.
You do?
I don't have enough experience yet to know if that's having a problem. Out in practice, you can just use Pylori or Helidac, or what we tell people to get their Prev pack, which has clarithromycin in it, and add metronidazole. But those are significantly more expensive than generics. For example, I can go to Walmart if they had tetracycline and buy the combination therapy for a 2-week course for $40.
Okay.
And if I buy Pylori, it's more than $400.
Right, and that's why this question is so important, is because even though the Heliadac, the Pylori, the Prep Pack are alternatives, they're so expensive. So it does sound like you're saying that maybe we don't know for sure evidence-wise if doxycycline can be used instead of tetracycline, but you're doing it. Is that correct?
We're doing it to the patients who can't take the other therapy or fail the other therapy. We're at least trying it.
So it's an option. It sounds like it's an option because right now the way we have it worded is don't switch to doxycycline, but we might need to soften that a bit, I'm thinking, that particular recommendation. Okay. And Karen, any other questions? And then we'll move on to our next topic.
There are questions about whether it's wise to delay treatment until you can get the antibiotics. What are your thoughts on that?
Well, you get infected with this organism as a child, and you get clinical disease when you're an adult or older. And so therefore there's never a rush to start therapy. But are these, I've been waiting a long time. I have another study that I finally had to abandon because I've been waiting a long, long time for tetracycline to appear. And So I don't know how long you'd have to wait, but I don't see any problem with that. We know how to treat peptic ulcer disease, etc. And so it's rare that emergency treatment of Helicobacter pylori would be necessary.
Yeah, I don't know if you have
In
a
fact,
point in the
I can't
article,
think of
Sherry.
an indication.
I mean,
Okay.
it's the anti-acid therapy that's healing the ulcer acutely, and this is really about preventing recurrence. It doesn't play a whole lot of role in the 2 or 4 week healing rates.
Okay.
That's right.
All right. And I do want to move on. However, we just got a question just in, and it's a really good one. And so I'm going to try and pin you down, Dr. Graham, and that is this whole area of H. pylori is how there's a lot of uncertainty in practice. That this particular physician uses the word enormous uncertainty. And you know what they want is a very clear single recommendation for the best regimen. Now, can you give us that? I know I'm trying to pin you down, but I'm just really trying to help these practicing doctors out there.
I get a lot of phone calls from those practicing doctors, and they ask me what to do, first therapy, and I tell them a concomitant therapy is my first choice.
Okay,
for
concomitant.
The average person.
Okay,
and
for the average
if the
person.
patient's been treated before, then it's the other therapy, which would be bismuth quadruple therapy.
Okay. Got it. All right. And that's what we're going to clarify that recommendation in our article. So thank you so much, Dr.
Can I say, Sherry, while we have David, I don't know that our lab is doing sensitivity testing. Is that more common? How many people are, does Dr. Graham know how common is that around the country to be doing sensitivity testing for?
I do it, and that's about it.
Okay. Send all our samples, Dr. Graham.
Okay. Well, thanks so much, Dr. Graham and other panelists, for your thoughts on those recommendations about how to treat H. pylori.